So my brief over the next 20 minutes is to talk about egg vitrification, which might be pertinent to some of us, and also to talk about what happens when cancer is diagnosed in a young woman or man who might need to have fertility preserved. So let's get into it. So fertility potential diminishes with age in women. You probably have heard this already a few times in the last 24, 48 hours. This is due to a decrease in egg count and quality. So at birth, there are about 1 to 2 million eggs, which then decreases to about 200,000 at the time the lady first has the first period at puberty. And the loss of eggs is then accelerated after the age of 37. So the highest complement of follicles or eggs is actually when the woman is in utero, is in the uterus of her mom at about 20 weeks gestation. That's when the highest follicles of numbers of follicles are. And then it decreases rapidly to about 1 to 2 million at birth, and then by the time you get to the age of 40, there are actually very few, probably about 1,000 left, and the quality is not so great. And the other part of my talk is talking about cancer treatment, which often involves the use of chemotherapy and radiotherapy, and this could irreversibly damage the function of the ovary. So the ovary is, again, one of those organs that has a rapidly dividing cell all the time, and the cancer drugs and radiation is targeted towards those kind of cells. So unfortunately, the side effect of knocking the cancer cells will be to knock the ovary and sometimes the testes as well. So what's the nature of the problem? Women are choosing to delay the onset of childbearing due to the need for professional achievement, higher degrees, and the need for financial stability. So this is not a trend that is peculiar to South Africa. It's a trend that is worldwide. And the fact is that you feel that you need to be at a better place by the time you want to start having children. By the age of 45, and I want this to sink in, about 99% of women will be infertile. So it brings home the fact that, if you're getting close to the age of 40, you should start thinking about doing things about it, and we'll talk a bit more about that. There's also a higher rate of miscarriages among the older women, and this is, again, a function of those eggs that I mentioned earlier. So the eggs don't only decrease in the amount, like we've explained, but also in the quality of them. So they rapidly age. So by the time you get to about the age of 39, 40, you're more likely to have a miscarriage because the eggs don't divide the way they should when they're fertilized compared to when you were 25 or 28, for instance. So the quality and the quantity of eggs continue to decrease to a point where pregnancy is then no longer possible, in the woman's age. Now, this is important to realize that this is related to the ovary. Okay, so it's got to do with the eggs that are made in the ovary. The uterus itself does not age. So in other words, if you have a normal uterus, you can get an embryo in there. So if you get young embryos into that normal uterus that is prepared from our previous talk, and you put the embryos in there, you can carry a pregnancy at the age of 65. Okay, so the uterus itself can carry that pregnancy, but the ovary will not be able to make, those eggs to get the right embryos. We do not make 65-year-old women pregnant often. Let me just make that clear. And I think the idea is, it's not that we cannot do so. Of course, we can physiologically, but you have to think about the child. So in other words, if you are 62 and you have your first child, by the time the child is 15, you're 75. By the time the child is a teenager, you're close to 80. It becomes a bit tricky to relate to that child properly in terms of offering that child, good sort of care or good motherly care. Same applies to the fathers. The problem with that, though, is that by the time the women are able to afford IVF and probably even egg donation cycles, they are of an older age anyway. So it's a bit of a toss-up trying to weigh at what level do you say it's okay not to have kids anymore? At what level do you say it's okay? Most royal or most of the big fertility bodies will say up to the age of 52, that's okay as far as uterus is concerned. But above the age of 55, you've got to be a bit more careful. And that's just related to the ethics of what I mentioned earlier, not the ability of the uterus to carry the pregnancy. So just to give you an example, these figures refer to what happens when you're having IVF related to your age. So in other words, if you're less than the age of 35, and this is looking at quite a number of cycles over a number of years, your percentage of cycles that result in a live birth is up to 41% with IVF. If you're between the ages of 35 and 37, that figure goes down to 32.2%. If you're between the ages of 38 to 40, you're talking about 21%. And if you're 41 to 42, about 11.1% chance of success. And over the age of 42, you can see how low that figure is following IVF using your own eggs. It's about 3.6%. And again, I need to make this clear. I'm talking about the use of the individual's eggs themselves. If you're 55 and you have a donor who's 22 or 23, your chances of pregnancy is as good as 50 or 60%. So different story, just using their own eggs. So that brings us to the topic of egg freezing or vitrification. What does it mean? It's an established method of fertility preservation. So in other words, it's been around for a while and it's quite successful. Useful for women who do not want to create embryos. So just to make this clear, if you are in a relationship, married, and you're sure you're going to have a child with that person that you're with, then it makes sense to freeze embryos rather than just eggs. And embryos are when the eggs and the sperms come together, they form an embryo, and they actually freeze better. We've been freezing embryos for a long time, 20, 30, 40, 50 years. Egg vitrification or egg freezing is relatively newer. So you can argue that we're not as good at it as we are with embryo freezing. So if you have a partner, or you're happy to use donor sperms, for instance, we can freeze embryos for you. But we can also freeze eggs, and we're getting better at doing that. So if you do not have a partner or you don't want to use donor sperms, we can freeze your eggs. And it's evolved over the last years from slow freezing, what we used to call slow freezing, to a rapid form of freezing called vitrification. So you see me refer to egg freezing as egg vitrification. That's what most labs do now. And that's because you get the eggs to survive for longer when you thaw them, when you vitrify, compared to when you do the slow freezing. So most labs do egg vitrification now. It's important to realize that the highest probability of a live birth following egg freezing is in women less than 35 years old. Okay? And counseling on egg freezing should be directed at women between the ages of 30 and 35. If you're below 30, we can freeze your eggs, obviously, and you have a good chance of using it later. But studies have shown that in those women, often they don't come back to use those eggs because above the age of 30, things become a bit clearer. They're in a different relationship that is rewarding, and they can have kids on their own. So oftentimes they don't come back to use the vitrified eggs. The good time to do it is between the age of 30 and 35 if you don't see having a baby in the future or in the near future. And that's not to say you can't do it for older women, but that's probably the optimum time to have it done. And just to give you figures, if you have 10 eggs that are frozen for women between the ages 30 and 37, the probability of achieving one live birth using the thawed eggs, so those 10 eggs, you thaw them or you warm them up, the probability of achieving a live birth at the age of 30 is 69%, and at the age of 37, drops down to 50%. So again, just gives you an idea of what we're talking about at age and when the freezing should occur. So what are the factors we consider when we're freezing eggs? Obviously, the age at the time of the procedure is important. I've just mentioned that the older the woman is, the lower the probability of childbirth. So that needs to sink in, that needs to be understood. But this technology has also been shown to be beneficial in older women, probably up to the age of about 45. But the important thing to realize is that at 45, you're not going to get 10 eggs when you stimulate those ovaries. And you might need to do quite a few cycles to get a cohort that you can work with later on. And then it becomes quite expensive. So in those women about that sort of age group, you do test for ovarian reserve, which is like an AMH or antral follicle count or FSH, whatever the lab does. It gives you an idea where you are. In most women that age, the AMH is usually too low to try and do anything with it. But if you're in that age group and your AMH is still okay, we might be able to do a few cycles and freeze those eggs for you, bearing in mind that the chances of success is still not as good as if those eggs were frozen sort of much earlier. It's again important to look at when the woman plans to have a child. So if you're thinking, I'm going to have a child at 36 or 37 and you're now 34, might not be the time to freeze your eggs because it's too close. You might want to go ahead and just cut your losses and have a child then anyway, rather than want to freeze for a couple of years. So in other words, the longer you freeze for, the better benefit you probably get. So the younger you freeze, the better you get. And just to dispel a few rumors, the risk of miscarriage is comparable to miscarriage rates following naturally conceived pregnancies. So if you have a pregnancy from an egg, from a vitrified or frozen egg, you have the same amount of miscarriage rate that you would have with naturally conceived pregnancies. The procedure is relatively safe. I will mention how we do it, in a second. It's a safe procedure, it's established, and very few risks involved. The pregnancy itself is exactly the same as you expect in a woman of that age that is pregnant. And those children so far has been shown to be just as normal as children you get from normal IVF pregnancies or normal pregnancies as a whole. There is no increased risk of congenital abnormalities, so no increased risk of an abnormal baby following pregnancy that you used a vitrified egg for. And this is important, that last point. How many women would regret having their eggs frozen? Very low. Generally, it's not something that people look back on and say, I shouldn't have done that. But it's linked to poor egg yield. So if you go through the process and we only get 2 eggs, you tend to have a feeling that maybe I shouldn't have done it compared to if we get the adequate number of eggs. And again, that just depends on how much counseling is done. So when the woman comes in, when we're talking about this, she needs to understand what the risks are, what the expectations are for our age in terms of how many eggs we might, sort of retrieve. So what about the process? So if you want to have your eggs vitrified, you obviously need to see a fertility specialist who will do a consultation, find out how old you are, what pregnancies you've had before, and stuff like that. We'll do a scan to check your antral follicle count, which is just checking how many follicles are in the ovaries that might have potential. And like I've mentioned, you do ovarian reserve testing, which normally includes anti-Mullerian hormone, and then counseling as to what needs to happen. So that's the first step. And then the next step is injections of Gonadotrophins, which is quite similar to what you have with IVF. So we give injections on a daily basis, usually for about 10 to 14 days, sometimes less. And in that time, we do ultrasound scanning to check that the follicles are growing. In essence, what you're trying to do is get those ovaries to grow follicles, get those small follicles to become bigger follicles that then have mature eggs in them. Some labs would also do blood tests as well to try and check if your estrogen levels are going up, but mainly scans to try and get to that point where we think those eggs are actually mature. And then we retrieve the eggs with the help of an ultrasound in theater. So usually the patient has some kind of conscious sedation or kind of mild anesthesia. Process takes about 20 minutes, maybe 25 minutes. You pass an ultrasound vaginally. There's a very thin needle that is guided into those follicles, and those follicles are then aspirated and they are kept in the lab and frozen. The follicles are then initially looked under the microscope. Usually when you do an IVF cycle or you do a stimulation like this, the follicles will be in different levels of maturity. So the mature ones are frozen. The ones that are not matured will be looked at again the following day. And if they've matured further, then they could be frozen the following day as well. And there is some evidence that higher the number of eggs you have frozen, the higher your chance of having a live birth later on. So sometimes we advise not having one cycle, but having 2 or 3 cycles, so we get a bigger cohort of eggs to choose from. Obviously, it becomes more expensive, when you do that. But that's pretty much what the process entails. And this is what happens in the laboratory. The egg is collected under room temperature, 37 degrees, and then it's exposed to a concentration of cryoprecipitants that actually freezes it in a cryotop, which is that little bit there, and that's then frozen in liquid nitrogen at that temperature, and it's kept at that temperature, minus 196 degrees centigrade, until we need to thaw it and then use it for fertilization. So again, just to give you an idea of what I've been talking about, step 1 there refers to egg production and stimulation, and then step 2 is where you collect the eggs. So you stimulate the eggs with the injections, you retrieve them, and then if that is what you want to do, you're looking at vitrifying them straight away. In most labs, an average of about 33,000. That includes medication, stimulation medication, and the laboratory fees. You might expect to pay a yearly fee to keep the eggs frozen after that. So this is with the initial outlay, and then there will be a yearly figure of between 5,000 thereabout to keep the eggs frozen for you as long as you want it frozen for. If we're talking about embryos, which I alluded to earlier, then you go 1 step further or 2 steps further. You either inject, which is ICSI, the eggs directly into the sperms, or you just incubate the eggs and the sperms together and you get embryos, which are actually more stable, and those could also be frozen, and then the cost is then about 45,000. If you go to the point of a normal IVF, where the transfer is done, then you're looking in private practice, anything between 60 and probably 80,000 to have that done. All right, so that's the first part of the talk, which refers to egg vitrification, why we might want to do it, what the indications are, what the ages are where you might want to consider it. Now let's talk about cancer and reproduction. Unfortunately, young women often get diagnosed with cancer, and the treatment that is often offered is chemotherapy and radiotherapy, and this knocks the ovaries, like I've mentioned earlier. So if you look at women who are childhood cancer survivors, they have early menopause in about 1/3 of cases if they've had chemo and pelvic radiation. So about 1 in 3 of women who have had chemo and radiation therapy for cancer would go into the menopause early. The menopause is the end point of reproduction. The ability to conceive stops before the menopause. So in a normal woman, the average age at menopause is 51. But like I've mentioned earlier, above the age of 42, you already start struggling to conceive. So ability to conceive precedes menopause by quite a few years. But if you're looking at early menopause in these women, it means that the ability to conceive is actually a bit sooner than that. However, with appropriate pre-treatment counseling and intervention, biological parenthood is often possible. So if you intervene early before the treatment is given, you can preserve the fertility and come back and use it later on. There is often a shortage of time, so time is of the essence here. This patient has been recently diagnosed with cancer. You want them to undergo treatment as soon as possible. So the treatment and the discussion around ovarian preservation or fertility preservation should be done about the same time and should be done quickly. Some units where this is established have a 48-hour turnover from diagnosis to when the freezing starts or when the process of sort of preservation starts. I think in South Africa, you're probably looking at, if you're in the public sector, not all the hospitals will offer that. I don't actually know of any that does, unfortunately. But in the private sector, you could pick up the phone any of the private clinics, and they will be able to help you with that. Many oncologists are worried about the use of hormones in women with estrogen-dependent tumors, namely breast cancer. So if you have an estrogen receptor-positive breast cancer, there will be concerns about shooting up your estrogen levels by giving you those stimulation that I mentioned earlier, because that's going to increase your estrogen levels. So you might have to modify the treatment in those sort of cases to try and retrieve the eggs. So in other words, fertility preservation, therefore, you need to individualize, you need to look at every patient as an individual and the circumstances around it. So you look at the planned treatment, the time available, the patient age, specific disease, partner availability, and cost. So this is a very busy slide, this next one. I don't really expect you to sort of follow that algorithm all the way, but this is a typical algorithm that most units will use. So it depends on where you fall into that category. So in essence, it's actually too small for my eyes to read here, unfortunately, but I hope you can read it from there. So the age of the patient matters, whether it's an estrogen-sensitive tumor, whether the patient has a partner, we go in embryos, whether the patient is young enough to not be able to have stimulation done. So if you have a very young patient, say 7 or 8 year old with a tumor, you might not be able to retrieve eggs like I've described earlier in that young patient. What we do with those patients, we do a laparoscopy, which is have a look directly into the abdomen with a camera, and you can then take slices of the ovary and preserve that instead. So instead of preserving the follicles, you're preserving ovarian tissue, for those young girls. So it all depends on where they fit into that algorithm. But that's a sort of typical algorithm that most units will follow to try and determine what we do for these young girls. So these are your options, really. You can't prevent ovarian failure. You can try and prevent ovarian failure when the patient is having chemo or radiotherapy, or you can freeze. So to try and prevent ovarian failure, you can try and suppress the ovary during treatment. So sometimes you got patients who have breast cancer newly diagnosed, they have to go through treatment. You can give them GnRH agonist, which makes the ovary quiescent when they are undergoing treatment. In other words, try and shut it down while they go through treatment. The treatment sometimes works, sometimes it doesn't. What you really want to do is to be on this side of the treatment. The other option is if she's going to get pelvic radiotherapy, you can just leave the ovaries out of the way of radiation to try and protect the ovaries that way. But what's more established is what we've discussed already, which is embryo freezing, oocytes and egg freezing, and that last bit in the young girls where you can actually take ovarian tissue and actually freeze that and use later on. And this is an example of how that is done. That's a laparoscopic procedure. That's a uterus there. That's the ovary there. You dissect, you take the ovary out, and then when the whole treatment is completed, you go back, make a little window there, and put the ovary back in there, and that's one of the things you can do. Are there other methods that we can use to try and preserve or restore fertility? Yes, there is. Conservative surgery, so if you have a cervical cancer, for instance, we might be able to just remove the cervix rather than remove the whole uterus, which allows you to retain some fertility potential. Alternative therapy for cancers in the older women, you might do hormonal therapy rather than chemo or radiation. Egg donation is established. We do a lot of that. So in other words, if the ovaries are not functional anymore and you have a functional uterus, you can get a young lady to donate an egg for you, fertilize with your partner's sperms, and Bob's your uncle from there. Embryo donation from previous couples who've had IVF before and they have an excess of embryos, they sometimes donate to other people, and you could easily have that, put it in through for you. Others include surrogacy, adoption, and uterine transplantation, which we don't do so much of. We haven't done one in South Africa, but in other parts of the world, we have done that. So what are the take-home messages? Women should not delay childbearing for longer than necessary. It's important that you want to, do those things that we mentioned about make sure that your career is up and running, all that. But if you're in a window where you're thinking, let's wait 5 years or can we do it now, rather do it now, okay? Egg freezing is available and allows women to retain the ability to conceive later on in life. Women should discuss fertility preservations. These sort of discussions should not be just here. It should be at home, with family, with friends, over a glass of red wine, whatever you need to do to have this so that people would know about it. They should know it exists. Women in their 30s should start considering fertility preservation if pregnancy making is not in the near future. And the treatment of cancer in young women should include discussion around fertility preservation. Thank you very much.